morning. I will be presenting the challenges encountered and hurdled by St. Luke's Department of Anesthesiology during the pandemic. Prior to COVID, anesthesiologists attend to cases in the operating rooms located in different floors of the main hospital building and in non-operating room anesthetizing locations in different floors in 3 different buildings. We also attend to ward calls like pain management. With the declaration of the pandemic, procedures considered as anesthetic cases, both diagnostic and therapeutic, decreased from an average census of 1,500 per month to 200 in April. However, the scope of operations of anesthesiologists increased to include the entire hospital, including critical care areas, both COVID and non-COVID, attending not only to airway management, but also for codes, checking of invasive lines, to name a few. COVID intubations outside of OR, which was classified by Philippine Board of Anesthesiology as critical care management, increased from an average of 6 per month to about 100 in July. With the increased scope of operation, the number of residents was capped to less than the skeletal force. This is to reduce their exposure and at the same time to observe physical distancing at the lounge. Consultants augment this decreased manpower. This proved to be of benefit as weaknesses in some areas and systems were observed closely. Intubation is an aerosol-generating procedure which requires critical care and ideally a minimum of 2 persons. To lessen calls secondary to extubation, guidelines for sedation for mechanically ventilated patients was crafted. This is in addition to airway management algorithm of COVID outside of operating room for safety of both patients and healthcare workers. Sharing knowledge and troubleshooting ventilators was also done through guidelines, which we shared to emergency room, ICUs, infection control service, and quality patient safety of the hospital. By March 16, after attending training on donning and doffing, consultants initiated simulation on airway management while observing physical distancing. Observations during calls the previous week were incorporated. Communications were enhanced through non-stop Viber messages that serve as learning opportunities for residents and consultants alike. The didactics of the residents continued. The online module, which started even before the pandemic, became the norm. Clinical case conference proceeded as scheduled, while quizzes and case presentation contests for the year were done earlier so that the residents who are not on duty will still have guided learning. These are also an opportunity to check the well-being of those who tested positive or those who are on quarantine. Short prayer and sometimes exercise are conducted prior to these online activities. Lectures from graduates who are practicing or are taking fellowship training abroad became easier with virtual platforms. As anesthesiologists do high-risk procedures in high-risk areas, the department has to constantly remind its members on how to protect oneself. Reminders issued by hospital and other organizations are for the community and for the majority of healthcare workers, like observing physical distancing. No reminder for those who do aerosol-generating procedures, wherein one is 0 meters away from a patient without a mask. Our reminder, which include identifying different masks by the color of the strap, are for those who do high-risk procedures. By May, as we see a prolonged pandemic, anesthesia algorithms for operating rooms were crafted not only to protect patients and healthcare workers, but to improve communications, which were made difficult by the level 4 PPEs during surgeries. In addition, these guidelines minimize standby equipment that will be discarded due to contamination. Pre-admission anesthesia clinic, which we call as PARES, which involves airway assessment, has shifted to telepares. This will be blended with face-to-face clinic even after the pandemic. Thus, all anesthesiologists, residents, and consultants were required to attend certification course on teleconsultation. This is aside from regular trainings on ACLS, pulse, infection control, and DEPADAC. The department was also visited online as we are due for accreditation by the Philippine Board of Anesthesiology, who also allowed us to contribute by participating in the conduct of the first online written examination and the online in-service examination. In summary, postgraduate medical education in time of COVID is continuous and two-way learning between trainers and trainees. The often used term, my student, my teacher, has become very true. But more than that, other personnel became teachers as well. The enhanced communication between different members of the hospital has become the silver lining of the pandemic. Man's weaknesses were magnified by the pandemic, and yet in the department, its manpower proved to be our strength during this COVID pandemic. Forward-looking, with the segregation of COVID and non-COVID areas in the hospital, including operating rooms, ICUs, and wards, we see an upward trend on the census of anesthetic cases. Prior to the pandemic, less than 50% of cases were attended to by residents. By their second year, we encouraged them to complete their required number of cases. With the decreased census, the present first year are still expected to be able to fulfill their required number of cases if they will go on every 3-day duty as they used to before the pandemic. They are still advised to leave after their cases. Being one of the oldest department of anesthesiology in the country, as old as its specialty board, we will continue training future anesthesiologists. We have shortened the preparation for residency from 1 month to 1 week, with 1 trainee at a time. We utilize online platforms to reinforce actual preparation for the training program. Thank you very much for allowing us, anesthesiologists, to present our experiences during the pandemic.